Dying is not a bad word. Death is not a bad word.
Welcome to the Stroke Cast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 103 of the Stroke Cast. We don't like to think about, what it means to die, about what that experience looks like. But many of us will one day finish out our lives in hospice or watch someone we love go through the hospice experience. And nursing care in hospice is a large part of today's episode. Today, I talk with registered nurse Barbara Sussanne about her career as a traveling nurse, working with stroke patients around the country, and end-of-life care in hospice. So now, let's meet Barbara. Barbara, I'm so glad we can connect here on the JoCo cruise, my 8th cruise, and I'm thrilled to just continue to meet so many amazing people, and right before the cruise and then right on it. So thanks for being on Strokecast this week.
Thank you.
Your background is in nursing in all sorts of different areas, which means you certainly encountered a lot of stroke survivors and stroke patients who unfortunately didn't become survivors.
Right.
How did you first get into nursing?
I actually, after the birth of my first child, thought I wanted to be a midwife and decided that during nursing school that mother baby was not for me. And my dad had had a heart attack followed by a 5-vessel bypass when he was 49 years old.
Wow.
So I just was naturally drawn to cardiac medicine, which encompasses not only the heart but strokes. And finished up my nursing career, actually worked at the big Jewish hospital where they did the first artificial heart. That was my first job.
Oh, wow.
I worked there. I just fell in love with the cardiac medicine and then worked some ICU step down, was a travel nurse for a few years, settled eventually in Memphis. And I've been working cardiac medicine, ICU step down, went to case management after I decided hospital was not for me, and now I work hospice.
So what is ICU step down?
It's people that still need very close monitoring, who are very fragile, but are not sick enough to be in the intensive care unit. It's also called a PACU. PACU is actually can be either post-anesthesia, but it also can be used as a term for it's more than a regular medical floor.
Okay.
But it is, it's where people need more monitoring than on a regular floor. Usually ICU have 2 patients to 1 nurse, and the standard of care is usually, if in a step down, is 4 to 5 to 1 nurse. The patients are almost always on heart monitors. They're monitored more closely. We can do, on that type of a floor, more interventions than that they can do on a regular medical floor. So it's kind of like that in-between state when you're coming out of the ICU, or if you just present to the hospital and you're not sick enough for ICU, but you need more than you can get on a regular floor.
Right. So that's basically where I think I ended up. I came out of the ER. They didn't do any of the procedures, and they moved me to a neuro critical care floor, which is probably like a step-down ICU.
No, actually, neuro ICU is just that. It's an intensive care unit that specializes in intensive care.
Oh, okay.
And in neurology. And there are cardiac ICUs, neuro ICUs, that where those nurses and those personnel specialize in that area.
Well, that makes sense. Well, I do know my nurses there were absolutely fantastic. I went back
to hear that.
Like a year and a half, 2 years after I got out to say hi to Jizuki, who was the one I remember from day staff. She had no idea who I was, but that's good, because that means I looked a lot better than I did the last time she saw me.
Absolutely.
So you've worked these floors, and
with these different environments, you've gone from being that regular hospital staff to then being the traveling nurse.
Yes.
So what is a traveling nurse?
What a travel nurse does is we go from hospital to hospital all over the country, some even internationally. We go to these hospitals. We fill spots where there's shortages, whether it be from just a general understaffing or 3 nurses are on maternity leave at the same time. We go.
It's funny how that happens.
Oh yes, it's in the water. But so we just fill that short-term staffing need. Initially, contracts are 8 to 13 weeks. My first contract, I went to Los Angeles. I was at the big LA County Hospital. I stayed there for 10 months and then went to another hospital in LA County, just north of there on the other side of the mountains, and was there for another 6. It's just depending on need. I've been in, the big LA County Hospital. That's the biggest hospital I've ever worked in. It was a teaching hospital. It was a wonderful environment to just learn in. Smallest hospital I worked was in northern Nebraska. We were 120 miles south of the South Dakota border in the middle of winter in a 30-bed critical access hospital in the middle of nowhere.
Oh, wow.
Yeah.
So when you're traveling and doing those assignments, are you typically then living out of a suitcase in an extended stay hotel, or?
Typically the way the industry worked, and this has been 15 years ago,
Sure.
Or not quite that long, about 12 years ago when I stopped. Basically you walk into most places a fully furnished apartment, kind of like a business apartment. It's fully furnished. You bring your own stuff, and when you leave, you pack it up. I actually had a small SUV full of stuff. I had my own TV. I had my own towels because I'm very picky.
Sure.
I had my little SUV, and I just drive across the country wherever I needed to be. I've been Texas, Nevada, Nebraska, California, Kentucky. Even did a 3-week stint in Phoenix, Arizona in the middle of summer.
Oh, I've been to Phoenix in the middle of summer. I don't know why they thought it was a good idea to put a city there.
I don't either.
But yeah, you really get to see a lot of the country then, a lot of the country at its best, and a lot of the country at its worst.
Yes, and I've had the opportunity to see things people have never seen. When I was out in LA, we had a patient with tetanus, which is something one doesn't ever see. Please make sure you're up to date on your vaccinations. It's a horrible, horrible illness.
Absolutely.
And
I've personally taken to, I no longer like to think of folks as anti-vax. I like to think of them as pro-plague.
Yeah, exactly.
It's like that positive mindset.
And I've actually taken care of a patient with plague.
Oh, wow.
Yes. When I was in LA County, we did have a patient who came in with a fever. We couldn't find what it was. She was finally diagnosed with plague that had been vectored in via either a mosquito or a flea from a rodent in the desert, because the rodents in the desert definitely they have this disease, and that's how it's vectored in. It was the first known case in LA County in 20 years.
Wow, that's amazing, and that gives you just a tremendous varied skill set to take to these other places.
Yes.
When you can then go into that. So when we're talking about then stroke care, I mean, I've talked in the past about why you want to be at a comprehensive stroke center that can do
Absolutely.
24/7 thrombectomy. It's why you call the ambulance to bring you there.
Yes,
you don't drive to the hospital yourself. Yes,
absolutely. If you're having a stroke, do not have somebody drive you. 911 is your friend.
Exactly.
And some major cities, and I currently live in Memphis, and we do have what they call a stroke ambulance that is specifically set up for patients they believe are having stroke. They can do a lot more interventions, and they can do things that can speed up the process in the emergency room. They have things ready so that they know more going into the ER, so they know whether or not, okay, do we need to look at this as an occlusive stroke, which means you need to go get the thrombectomy, and they need to get in there, and they need to get the TPA or the other medications that they can give you to dissolve that clot that is in there, or is it a bleeding stroke, which means they may have to take you to surgery.
Right.
What I like to say with regard to both hearts and stroke is time is muscle. In this case, time is brain. The longer you go without treatment when you're having a stroke, the worse the disability and the effects of that stroke are going to be down the road. I've seen patients who have come in, they can't talk, they're like paralyzed on one side. They get the appropriate treatment, they get the rehab, and they are nearly 100. They can be nearly 100% in the end. That's not. There are several factors that come into play here. First is quick, appropriate treatment, depending on the cause of the stroke, whether it's hemorrhagic or occlusive. The other thing is,
and the more common term for occlusive is clot.
Yes, ischemic or clot. Yes. The other thing is willpower. I have seen patients who come in with devastating strokes that were like going, they're never going to walk again. They're going to be dependent all their lives. But it's something in them, in their person, that says, I'm going to overcome this, and they go so much further and so much farther than we ever expect them to. And then on the other hand, we've had people come in with minor strokes that we're thinking, with some little bit of rehab, a little bit of, treatment, they're going to they can go back to a normal life and normal functioning, who wind up bedridden because they don't have that will to do what needs to be done. So your recovery is not only dependent on quick, fast treatment, appropriate treatment, but the other thing that does play into that is a person's inner will to get through it. Do I want to get through it?
Exactly. That's so great to hear coming from a medical professional. The way I describe it is that, a positive mental attitude is great, an action-oriented attitude is better, but it doesn't guarantee recovery.
No, it does not.
It is, however, a necessary element for recovery. You won't recover if you don't think you'll recover.
Absolutely.
If you believe you'll recover, you have a shot.
Exactly. And if you believe you'll recover, you'll probably go farther. You may not be back to 100%, but you are going to get to as far as you can.
Absolutely. So when we're talking about speed of care and all the different things that we can do now that we couldn't do just 15 years ago.
Right.
How does the stroke care then that you see in that LA facility compare to the experience in the Nebraska facility?
Well, what would happen currently in a major hospital like the LA County Hospital that is, if I remember correctly, is a level 1 trauma center or pretty close to it, you're going to go in, you're going to have symptoms of a stroke. The first thing they're going to do is they're going to put you through a CT scan, because that CT scan will tell the doctors whether or not you have a clot or whether you have a bleed. Those are, if you have a bleed and we give you drugs to dissolve a clot, we are going to kill you.
Yes.
We don't want to do that. So, the treatments are completely different. Speed is important. They talk about the golden hour.
And that's why I just want to take a moment and say there was some common wisdom a few years ago, which is, of course, a terrible idea, that if you think somebody is having a stroke, to give them an aspirin. And that's a terrible idea if you don't know what kind of stroke it is.
No, that's appropriate if somebody's having a heart attack. That is inappropriate if you're having a stroke, because if you give an aspirin, the antiplatelet, which means that what causes your platelets not to stick and form a clot. If you're bleeding, you need that blood to clot. If you're having an ischemic stroke, that will be helpful. But without that CT scan, without that vital piece of information, you don't know.
Exactly. So they get you into the CT to rule out a bleed.
Right.
Then often it's a follow-up with an MRI if available to assess clot detail.
Yeah.
Does a 30-bed facility doesn't
no, actually, yeah. And what would happen in that situation, if the ambulance picks somebody up, they actually would bypass our hospital because we do not have that we would not have that technology. and they would go to a bigger hospital down the road and even life flight them out if they were that critical. If they presented to our facility, basically we would package them up, call an ambulance, and send them out because we did not have a 24-hour doctor. The facility was so remote and so small that when we got a phone call that we had a patient coming in by ambulance, we had to call the doctor. I was at times the only RN in the building, and we had to call the lab tech, and we had to call the X-ray tech, and we had to call everybody to be there when that ambulance got there. It was a small 2-stop sign town.
Sure.
So it was pretty quick for our faculty and our staff to get there.
And you probably weren't getting like 15 ER admits a day.
No, actually a busy day in the ER on my shift would have been 3. So, and the most we ever had inpatient was 8. It was, not a very busy hospital, but, it's the first step is that EMS crew. If you are out in the community, the first step is that EMS crew, that EMT, that paramedic crew that's going to come and see you and go, we think you're having a stroke, and getting you to the appropriate facility. If you go yourself to a facility, it may be a facility that is not the best for what's going on for you. And again, time is brain.
Right, and then when you get there, you may have to wait in the waiting room and be triaged, whereas an ambulance crew does triage on the way.
Absolutely. And I mean, nurses and doctors, they do a lot in this, but a lot of people overlook the fact that what your emergency medical techs, your paramedics do when they're the first on the scene and they're doing the assessments and they're letting the hospital know that I have a stroke patient that's coming in, and these are the symptoms. It's very important if you witness somebody having a stroke. One of the most important critical pieces of information you can give that EMT or the doctor in the ER is when you first notice symptoms. That first hour is important. And the longer it goes, the more damage can be done. The thing that they look for is they say fast. You look, and I'm sure you've been over this before. You look at the faces, one side or the other drooping. You have them put their arms straight out and close their eyes. Does one arm droop more than the other? Their speech, can they speak properly? And then time. When did that start? The sooner they get to the ER, the sooner they get treatment, the better the results. And that's just. My friends look at me like I'm crazy, and they'll come to me and they go, "What do you think about this?" I said, "You need to go to the ER, and you need to go now, and you don't need to drive. You pick up the phone, you hang up for me, and you call 911."
Exactly. Do you remember the phone number for 911?
Exactly.
And when I say that, that's not a joke.
Yes, exactly.
As
and
your brain is going offline, you can forget how to operate your phone.
Yeah. Well, usually I'm talking to people going, grandma is this.
Yes.
It's usually not people calling me saying, I think I'm having a stroke,
Right.
It's mostly family members or friends going, I have this situation, help me through it.
Right. Absolutely. And you've gotten to encounter some more people in those different experiences, not just the ER, but as you started working with home care and home health care. And what was that experience like? How did you get into that?
I will be the first person to admit I am getting older. I actually just celebrated my 60th birthday a few months ago, and I decided that my body was wearing out, and my doctors said, your arthritis is going to continue to get worse if you stay in the hospital. So I said, you know what? For me, I have to walk away from this because 12 hours a day of lifting and pulling and tugging and pushing and doing that kind of thing was detrimental to my own personal health. And I had to say, I have to, I love my patients. I love working with my patients, but I had to find another way to do that.
Oh, definitely. We don't think about the sheer volume of workplace injuries that happen to RNs and other medical staff. I know when I was in the hospital, I was a 2P. It said 2P max on my on my whiteboard, and it didn't realize what that meant at first. That meant that it required 2 people to actually lift me with maximum assistance to get me out of the bed.
Yeah.
I was 275 pounds when I checked into the hospital. Lost 25 pounds in that month, but that's a lot of lifting for a lot of folks, and they're not doing it just for me.
Yeah.
And not everybody is as friendly and trying to help as I was.
Exactly. And I will say hospitals now, and a lot of especially like rehab facilities and nursing homes are actually going to no lift facilities where they're using, where they are actually tell staff don't lift and use a mechanical device. It is not only safer for the staff members, it's also safer for the patient, because they're not, if they start wiggling when they're being moved by people, that runs the risk of injury for both the personnel and the patient. If they use a mechanical lift or a mechanical device or an assist device, they are less likely to be injured.
Yeah, absolutely. There's no reason to be insulted when they put you in a room with a crane.
Exactly. And there is this neat new thing that is in the hospital. It is a special device that it's a wheelchair that lies flat. And what you do is you hook this long bar to it. You attach the sheet with giant-looking garter hooks, and you crank it, and it pulls the patient who is laying down in bed into the chair. And at that point, you sit them up. And then when they are ready to go back into the bed, you lower it, you put the bar on the opposite side of the bed, attach it to the sheet, you crank it, and it pulls them nice and smoothly into the bed. And at that point, you reduce the risk for injury to both your personnel and to the patient.
That's great.
Yeah, I think that is, I would love to have all my patients have that device.
Sure.
Unfortunately, it's very expensive, and I, for the life of me, can't remember what it's called.
Well, we'll figure it out and include it in the show notes. When I was my first night in the hospital and they wheeled me down for my second CT, they used this inflatable air mattress. So they roll me over, get me on this thing, and then it's like a hovercraft that slipped me over to the stretcher.
Yeah, exactly. And
that was kind of cool.
Yes, and the innovation of some of these things is so great. I am not a nurse innovator. I have, met a couple that. I met a woman, a nurse who. We were trying this thing out in one of our hospitals that looked like the little coffee cups that you get your creamer in. Only it had little sponge fingers soaked in alcohol that you would swab the hubs with on IVs to make sure that they were really clean when you use them.
Oh.
So, there are a lot of nurses and a lot of doctors that are looking, and other medical professionals that look at things, and I'm just amazed at the amount of innovation that's coming out nowadays to help patients, both on a high-tech level, like with what you were talking about, the
air bladder.
The air bladders, the crank bed that, again, I can't remember the name of. And just the simple things like, I went to a facility recently that uses pool noodles to put under the bed sheets to remind the patients where the edge of the bed is, some things low tech, some things high tech. It's amazing.
Yeah, it really is. It really is. So when you're doing home health care, what was that experience like in working with those stroke survivors who are getting care at home? I imagine they're typically dealing with a lot more severe disability as opposed to an at-home rehab type of thing.
A lot of the patients that I took care of were actually post-rehab.
Okay.
And had gotten as well as they could have. This is after you do the home health and the rehab and the physical therapy and the occupational therapy and all that. And these are generally patients who either have given up, and I've taken care of some of those that they've just given up, or their debilitation is so bad that they're going to need either a CNA to come in and help bathe them, or transfer them, or help feed them, to give the family a break, or may need nursing care if they are that severely debilitated from their injury. Feeding tubes, that's not an uncommon thing for somebody who has suffered a stroke, is that they have a feeding tube. Well, that's got to be a nurse to take care of that in the home. Families can be trained to do it, but scope of practice limits what CNAs and home health aides can do.
Right. And there's not so much we can do with bed sores.
Exactly, and the nurses can go in and treat the bed sores and do all that kind of thing. And I kind of managed all that care for our patients.
Wow. Yeah, a lot of the survivors who we've had on the show or we've had in this audience, we know that it's easy to forget that some of us do have those much more debilitating disabilities.
Absolutely.
And it's easy to forget that world is out there because those folks aren't getting out and sharing their stories.
Absolutely.
And it's so important to still be able to go ahead and take care of them. And especially the other thing that here on the cruise we had a meetup for folks with neurological conditions, stroke, TBI, MS, etc., etc. Pick your set of letters. And what's interesting too is just how much of this stuff is existing with other conditions. So you don't, especially as you live with disabilities and you're more disabled, you don't just have stroke stuff you're dealing with. You have other things that you're dealing with at the same time, and it all compounds, and especially in that scenario.
Because not only when someone has a stroke, you not only have to treat the stroke, you also need to treat the underlying cause of that stroke. Is it a stroke, an ischemic stroke, because you have a buildup of plaque in your brain? Similar like you can get one in your arteries in your heart. That needs to be taken care of through medication, or, if it's in your carotid arteries, do they need to go in and scrape that out? Put in a stent, fix that? Or did you have a stroke because you blew an artery in your head because your blood pressure is way out of control? Or do you have a natural defect in your blood vessels in your brain? And in that case, there's treatments for that too. But you not only have to treat the stroke, but you have to find out the cause of the stroke and see, is that reversible? Is that something that we can treat to keep this from happening again?
Absolutely. So you've covered pretty much the whole gamut of stroke experience, from arriving in that ambulance to then getting out of the ICU and into the step down, then into the post-rehab world. And you also, more recently, have been working in the far end that we don't like to think about a lot. A lot of us don't like to think about, but it is so important, and that's the hospice industry.
Yes.
How did you make that transition to hospice? And I guess for those who don't know, what is hospice?
Okay. The hospice is also combined with something that is called palliative care. They are frequently seen together. Palliative care is when somebody has a chronic illness or injury, like from a stroke, and they are undergoing treatments that can be life prolonging and curative. And I will use my mother, for example. My mother had cancer, and she was on palliative care for a long time because even though we knew the chemo and the radiation and all those treatments would not cure her cancer, it would give her a better and longer quality of life. Hospice, on the other hand, is when, in order to be eligible for hospice, your physician must deem you have a life expectancy of approximately 6 months or less. And our hospice patients have basically, if they've got cancer, the chemo treatments stop. We don't do aggressive treatments. It's all about giving them the best life that we can give them for the small amount of time they have left. That can mean, in the beginning, it's just supportive care, making sure that the supporting the family as this process goes by. Eventually, especially in stroke patients, along with dementia patients and other neurological issues, they lose the ability to swallow, and it's a lot of education in families that no, we're not going to put a feeding tube in, because what's happening is your body is shutting down, and everybody's does it in a different way, but usually, most likely, they stop eating. Sometimes by choice. It's like, I'm done, or they lose their ability to swallow, which is very frequent what happens when somebody's had a stroke. And so they come into hospice knowing we're not going to put a feeding tube in. We are going to keep them comfortable. We are going to manage their symptoms. And as people get closer to the end of their life, things happen where they start struggling to breathe. And we do medicate, we manage that with medications, most commonly morphine. Because morphine not only is a pain reliever, but it also helps relax the airways so people that are struggling to breathe can breathe better. We give them oxygen if they need oxygen so they feel better. We give them anti-anxiety medications to help with that. Whatever we need to do to keep that person comfortable in the final months, hours, whatever time that they have left. And we also we provide emotional support, spiritual support, social workers. Our team is social case managers, social workers, chaplains, and then there are people, our nurses like me. I'm what's considered on call. I go out and I see patients that are actively dying. I work the night shift. So I go into people's homes or wherever they happen to be, whether it's their home, a facility, either a nursing home, rehab, whatever, or actually we have patients in the hospital, and they're either having a crisis or, something like, Grandpa fell, we need you to come and check him out, or, Grandpa's having trouble breathing, please come check on him, or, we see people very frequently when we believe that they're within days to hours of dying, and we have a nurse going out every shift to check on them. And then something that my company, and I'm not going to promote my company, but it's one of the things that we do is...
if they're interested in sponsoring us, they can give me a call.
Okay. What we do is if we feel somebody's within hours of death, if it's acceptable to the family, and this is always dependent on the family drives this. We put one of our staff members in the home around the clock when we feel somebody is within hours, just to provide that support, to be an extra set of eyes. And it's usually not a nurse. It's usually during the day, it's usually a chaplain nurse, social worker. At night, it's usually a CNA. And, so if there's a need for the nurse to get there, it's something that our staff is trained to recognize a little bit faster. And then when eventually the person dies, and which is what we expect all our patients to do, our nurses go out, and this is what all hospice nurses do. We go out, and depending on the state, and this does vary state to state and who can pronounce death, but in where I work in the state of Tennessee, nurses are allowed to pronounce. We go out and we pronounce the person. We give the official time of death is when we get there. We do post-mortem care. We take care of their body. We make sure that, because when people die, they usually have a last bowel movement or a last urination, and we make sure that they're clean and they're neat and they're, presentable. Some families want us to do that. Some of them would prefer to do it. I've had families that wanted to do it themselves. we call the funeral home. We wait for the funeral home to get there. We support the family after that person has passed. And then we offer, as part of it, and all this is my understanding that all hospice companies do, because this is just my experience, both personally and professionally, is that there is also a follow-up for families for grief counseling, for a period of time afterwards. So hospice is all about, all that being said, hospice is all about maintaining a person's comfort during, the final months of life. I had a gentleman that I had the opportunity to take care of before I went, while I was a case manager, before I went to the on-call portion. And he was still working. His family owned a business, and he was still working in that business, and carried his little oxygen machine with him, and we supported him in that. We helped him do what he needed to do to keep that quality of his life up. And eventually, he could not leave the house, and he eventually died. But that's what we do, is we help them maintain that quality for as long as we can, knowing that we're not going to cure them, we're not going to fix them, but we're going to stay here, and we're going to help you die the best peaceful death the best death. And that's, dying is not a bad word. Death is not a bad word. It's, when I've seen some horrible deaths where when I was working in the hospitals, we're resuscitating 90-year-old people who 98% of the time don't pull through, and even if they do, they don't live very long. And then
resuscitation is very hard on a person.
Yes, it is. Yes, it is. And in hospice, we'll hold your hand. We'll give you whatever medication we need to give you to make you comfortable.
Because we're not worried about long-term side effects of those medications anymore.
And we are not. And we are not worried about addictions. And that's a common problem, too, where families think, they're going to become addicted. No, they're not. Not in this very short amount of time. I've had families going, if I give this morphine because they're hurting, I'm going to kill them. No, you're not. The disease is killing them. Well, Mama's not eating because she can't swallow anymore. That's a normal function. This is how it happens. And we do a lot of education.
So, you're really passionate about this space, and I can hear it in your voice, and this is such an important responsibility, but knowing your patients are not going to come out of this. How do you compare that experience as a nurse to your experience in the hospital, where you may see more patients and see them leave?
It took a big turn of my brain when I went from what I call regular nursing to hospice nursing. My only experience at that point had been my mother having cancer, and as a family member, and I believe it or not, at that point I said I could never do this. And just shy of 8 years of the anniversary of my mother's death, I was called to hospice. And it is a big turnaround, because you go from an ingrained notion that you can save everybody, and it's and you're trying to save people and make them better, and it's really hard to accept the fact that people die. You don't want to, while you know that, you don't want to admit that. You don't want to accept that your patients are going to die. And that is, some people can't make that distinction, and it is a problem. and there is efforts to talk with people and talk with families when, like if somebody has had an absolutely devastating stroke and there is no hope for recovery. Are we going to leave them bedridden? Are we going to leave them in a persistent vegetative state because of this? And they're going to have feeding tubes, and they're going to have, bed sores because they can't turn themselves, and they're going to need around-the-clock care, and they're not going to know anybody. Is it best to save that person, or is it best to put them on hospice and let them go? This is a good time to bring up making your wishes known. Pick somebody to be your medical power of attorney that is going to follow your wishes, and put it in writing. There are so many times when family members disagree on how to treat mama when she has had a stroke, or when she's had cancer, or when she's had a heart attack, or when any of that's happened. And it's very important to sit down and when you are able to make these decisions, because once this happens, you can't make that decision for yourself. You cannot do that. And it doesn't necessarily have to be a family member to make that decision for you. My personal opinion is that sometimes the best thing you can do is ask a friend. Don't, and I'm not saying it's a bad thing to appoint a family member, but sometimes the best thing is to appoint somebody so that your family doesn't have to make that decision and doesn't have to struggle with, I don't want to let go of mama, but this is what mama wants.
Right. Have that quarter step of detachment.
Yes, exactly. And that's one of the things that happens to be one of my soapboxes is, draw up your living will, your medical power of attorney. You can talk to your doctor and have what's called a post form done, which is I think it's physician's order for sustained treatment or something. And it says, it's actually a physician's order that goes to the hospital with you and says, I want comfort measures only. I want partial treatment, but short of being resuscitated and intubated, or I want full care. And then there's other forms that you can fill out at home and have notarized that say, I want A, B, C, and D, and that is so very important before something happens.
Right. And that brings us to our hack of the week.
Pool noodles. I have seen some very innovative things done with a pool noodle, both large and small. You can wrap them around things to grip them. You can use them as barriers for side rails. You can put them on the edge of your counters to prevent bumping injuries. I've seen small one used on utensils to assist with feeding. I just think they're great.
Fantastic. So Barbara, folks want to know more about you and what you're up to. Where should they go?
The easiest thing to do is JavaJunkie_RN on Instagram. Just message me there. I'll get it. I don't post a lot because I'm boring. I'm a boring geek. But
no such thing as a boring geek. Awesome. So we will have those links available in the show notes. Thank you so much for joining us this week. This has been great.
Thank you for having me.
The quiet passion that Barbara has for talking about end-of-life care is powerful. I mean, I felt it when I sat across the table from her talking during this interview, and I felt it again months later as I edited this episode. Her patients and her team really are lucky to have her in their lives. So now you're probably thinking, whoa, Bill, it's June 2020 and we're still in the middle of COVID-19. What are you doing sitting across a table from anyone? Well, Barbara and I actually recorded this conversation back in March really, it was right as everything was shutting down in the United States. In fact, we were on the Lido deck sitting in the buffet of the New Amsterdam Holland America cruise ship on its last cruise before cruising was canceled. When the boat left Fort Lauderdale, Florida, COVID-19 was just ramping up in the public consciousness. Countries were starting to shut ports, and we were all starting to think through our contingency plans. Some people did opt to cancel at the last minute from going on the cruise. But it was while we were at sea that the whole thing really blew up in the Americas, and we returned to a very different world. Fortunately, it appears that none of the 2,000 plus people on our cruise contracted the disease on the boat. The community I was a part of was quite diligent about hand washing and hygiene in general, and I'm sure there was a healthy amount of luck at play too. This cruise was actually the 10th sailing of the annual JoCo cruise. I've been on 8 of them so far, and I've booked the 2021 sailing too, assuming, of course, that it still happens. If you like board games, comic books, crafting, karaoke, or generally just hanging out with a whole bunch of nerds and geeks for a week, celebrating music and art and creativity and games of all sorts, go ahead and join us in 2021 or whenever the next one happens. I mean, I always have a great time on it. You can visit jococruise.com for more information. In the meantime, just be safe and continue to wear a mask and practice social distancing as appropriate when you leave the house. That's going to be it for this week. You can follow Barbara at JavaJunkie_RN on Instagram. You can follow me on Instagram as well, where I am at Bills_Strokecast, or you can just go ahead and visit strokecast.com/Instagram. Share this episode with someone you love by giving them the link strokecast.com/hospice so they can learn a little bit more about just what it is hospice means. And of course, as always, don't get best, get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you soon.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.